Everyone. Welcome to the session. Today, we'll be going over the impacts of housing instability on the health of vulnerable populations. I'm Dr. Kevin Lombardi, and I will be your guide today. And I will briefly pass it to my colleague, Pineda Sandoval, who will be introducing you to our session and our format today.
Thank you, Kevin. Hello, everyone, and thank you for joining us today. Before we continue, this is just some background information about the National Center for Health and Public Housing. This is just a reminder that the mission of the National Center for Health and Public Housing is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing a range of training and technical assistance. NCHPH is also a project supported by the Health Resources and Services Administration and is a national training and technical assistance partner that is 100% financed by this grant. The information presented today are those of the author only. And then here we're going to provide just a brief introduction about ourselves. Again, my name is Pineda Sandoval, and I am the TTA manager here at NCHPH. I will be helping and collaborating with Dr. Kevin Lombardi in facilitating today's session. And Kevin, would you provide your introduction?
Yes. Hi, everyone. I'm Dr. Kevin Lombardi. Thanks again for your service to your communities and for joining us today. My background is as a medical doctor and epidemiology, trained in internal medicine and statistical methodology. My research has been primarily around access to care and the social determinants of health, but I've practiced in internal medicine and dealt personally with this subject on a clinical basis for most of my clinical career. From the public health management side, I was the executive director of Your Story International, the international health, public health and primary care organization from 2014 to 2019, and managed a range of programs that dealt with housing instability and particularly maintaining appropriate clinical care of patients with chronic diseases in light of chronic homelessness or chronic housing instability. So this is a subject that is very meaningful to me on a professional and personal sense. I'm very happy to go into some details and to discuss some pearls and best practices with all of you. So Fide, I think I'll pass the ball back to you.
Thank you. Thank you. Also, I'd like to remind everyone that your line is muted. If you would like to also participate later on in our session, please make sure that you raise your hand and your line will also be unmuted. And then the slides and recording link will be provided to you after today's session. And now to continue, here is some other information related to the health centers close to public housing. According to 2022 UDS data, we had over 1,300 FQHCs that served to 30.5 million patients. There were 483 FQHCs that were intermittently accessible to public housing that served to 6.1 million patients. And of those intermittently accessible public housing health centers, there were 108 PHPCs that served to 935,823 patients back in 2022. And then here we have some public housing demographics data. This is from the website, the U.S. Department of Housing and Urban Development. This is based on 2023 data. And this data basically describes the demographics of residents of public housing and as it is displayed here, the 1.5 million residents demonstrate the characteristics that differentiate them from the general U.S. population. For an example, there were 2 persons per household per unit, 38% were disabled, 52% were white, 91% were of low income, and then additionally, 43% were of African-American descent, 26% were Latinx, 19% were elderly, and 36% were children. And lastly, 32% were female-headed households with children. Now I will pass it on to Dr. Kevin Lombardi, who will continue with the presentation.
Okay, so let's go to it. We're going to have a really focused and productive time with this material, and we're going to have a good time too. So just to give a quick overview of our learning objectives, we'll be reviewing data and scholarship from my research team that looks at some of the clinical and non-clinical challenges faced by our HUD-assisted families and our residents of public housing. We'll be describing how health centers and PHAs can utilize community health workers and community health worker-based interventions and public health programs to support families with housing instability from the range of housing instability and housing, and examine case studies that elucidate the impact of addiction, chronic disease, and social marginalization on vulnerable populations. Fide, could you progress, please? Yes. If you remember Fide's blurb about the health, HRSA, the government agency that funds us, that's a way of saying that we at the National Center for Health and Public Housing work for you. And this webinar is designed to be not just a performance, an educational product, but also a consulting product as well. Throughout the process of giving this this presentation, you'll see at the bottom, in the bottom left there will be links to the resources, we'll have a very specific format for how we are doing things today. Things will be very discussion based. We'll be examining case studies and discussing them together as a group. Perhaps the greatest benefit of the NTAPs and having access to sessions like this is the sorry, Fide, are you getting feedback as well?
No. No. Let me see. Maybe there's something going on here with my AC. Give me one moment.
Okay, I'm going to keep going. Please pop some. Excuse me, everyone, as we fix this.
Hello?
Okay. So Fide, I'm going to keep going. If anyone keeps hearing that, please put something in the chat. Excuse the upset. One of the main benefits of these sessions is being able to be in the audience with the range of professionals that we have here. The diversity is significant, and it's a great opportunity to share promising practices. Let's head on. Next slide, please. Some more details on that. Next slide, please. Okay, so let's start by please adding, and I'm sorry for the mistitle there, for our webinar, where are you joining us from and what's your role at your organization? I'd love to get a snapshot of the range of folks that we have with us today. So please pop that into the chat. Okay, next slide, please. And can you please, you all please throw that in as we're going through the next slides. So some information on the social determinants of health, which I like to see in this context as a epidemiological principle and a way of understanding patient care, patients' lives, and the influence between their environment and their bodies. Now, how do we translate this to the populations in question for this webinar? The unhoused, residents of public housing, the HUD-assisted, and people living in transitional housing. Housing is among the most core drivers of individual health autonomy. period. So much of the infrastructure of health is linked to an individual's housing status, their address, if they have an address, their ability to safely organize medications and be compliant with their prescribed therapies, their ability to access and maintain health insurance coverage. All are nearly determined by their housing status. If a patient is diagnosed with a chronic disease or a behavioral health condition, there are additional ways that lack of housing can be extremely significant barrier to care. Examples being psychiatric medications and inability of patients to be compliant due to their housing instability, addiction treatment and difficulties with compliance and exposure to drugs, chronic conditions such as COPD. Can you imagine having COPD and not having access to adequate housing? It's a terrifying thing to even consider, but these are real things that patients deal with on a daily basis. Next slide, please. The WHO conceptual framework, I put this in here because it's an important grounding principle for us as medical professionals and for those who work for health centers and PHAs. The concepts of the social determinants of health, they weren't just invented in a laboratory. They didn't come out of a vacuum. They came from the concepts and understandings of human rights. And this is the Enlightenment the Enlightenment tradition in medicine. And for those of you who are interested in sort of the basis of the social determinants of health from a scientific and social science perspective, take a look at this the WHO conceptual framework. It's a great read, great for a morning coffee. Next slide, please. So for learning objective 1, we're going to look over some recent research and specifically some research by my team on emotional well-being and housing status and the impact of housing status on emotional well-being. Now, this is an important topic because emotional status is deeply linked to behavioral health conditions, and the populations of focus for this webinar are disproportionately impacted by behavioral health conditions. So we're going to start with this data and then look at a case study that sort of takes it into the human realm. So just some details on looking at charts for those of you who aren't chart friendly. The 95% confident interval and the p-values are the kind of in statistical measures when we're looking at a results chart like this. Next, please. The results are understood as follows. For this study, I looked at a large national database of information from FQHCs, our health centers, and specifically their patient interviews. I essentially broke it into housing status and compared the individuals who were HUD-assisted and public housing, both to people in normal traditional paid housing. And it gave us some insight into the impact of behavioral health conditions on these populations. Next, please. So let's look at some of the data here. This first one, this was from a depression questionnaire that was given to patients from FQHCs. The population size was adjusted to 30 million using statistical methods. So this is very good data. Next slide, please. So as we can see from the question, during the past 30 days, how often did you feel that everything was an effort? The correlation here is significant. For all FQHC patients, they reported a rate of 29.8%. For HUD-assisted patients, it was so much higher, 43.1%. Next slide, please. And next. So a similar question from the depression questionnaire shows a similar divergence between these populations. As we can see, when asked how often patients felt that everything was an effort, all or most of the time, a key indicator of depression, our HUD-assisted patients were nearly twice as likely to indicate those feelings in the last 30 days. Next slide, please. And any feelings of extreme sadness as defined by the patient. Next slide, please. Let's look at the difference here. For FQHC patients, in general, 30% are saying that they have felt so sad that nothing could cheer them up in the last 30 days, which is, I think, an important metric for us to reflect on, that the challenges that our patients are feeling both in their medical and non-medical lives. But the disparity between all HUD-assisted patients and FQHC patients that are not HUD-assisted is very stark, again, at 41% versus 29%. Next slide, please. So let's now transition to our second learning objective and talk about program interventions. And for the purposes of, if this was a semester-long class, I would love to go through every program intervention that works for individuals with housing instability. But it is such a broad subject because housing instability has such a severe impact on health and wellness. But two, patients experience housing instability in such a wide range that it makes every situation very unique, and it necessitates that each situation as such requires a individualized approach. Excuse me. Patients with housing instability rarely need anything besides comprehensive support. This means that knowing your resources and being able to network, support, and coach patients through them, and by them, these housing issues, are cornerstones of competent care. Now, based on my consulting with FQHCs on this subject, when I was reflecting on it, the three main areas that popped out as program intervention guiding principles that I wanted to use to transition to our material are as follows. And one is become a partner. The CHW-based coaching and navigation model is among the best supported by research for supporting individuals with extreme SDOH issues like housing instability. These patients are often housing unstable and dealing with many other challenges, and it really requires a detailed approach. The CHW-based coaching and coaching system is among the best studied and among the most effective in providing cost-effective and comprehensive support to patients with housing instability. And we'll get into some more details about that in a moment. But more on navigation, and I want to emphasize the importance of knowing the environment. And by the environment, I mean, what is the social service and so the availability of social resources in your environment, in your service area. Having access to that information is important because it allows, one, for you to be able to network patients quickly and efficiently, but two, it allows the potential and for the propensity for partnership. Frequent referrals to a social service, a charity, or a partner organization, or a potential partner organization in your area allows through reflection, opportunities for partnerships, cost saving, and cost sharing. So I can't emphasize that enough, that part of having a robust social support system is not just knowing the resources, but building the partnerships to decrease the costs and decrease the friction, because that does translate to better health, not just better patient care, but better and more efficient health center management and personnel management as well. And third, the focus on cultural competency and diversity. Housing instability can be humiliating to patients. It can be difficult for patients to even mention that they are having the issue. And it can be difficult to coax patients to accept care and support in many circumstances. And ensuring that your CHWs, your social support system, and your physicians, anyone who touches the patient or talks to the patient, has training in cultural competency and diversity is extremely important. These are individuals that can feel judged very easily, and having an understanding of both how our spoken and expressed language impacts people from different backgrounds is very important. So regular diversity and cultural competency trainings are extremely important, but also pushing your clinical staff and pushing yourselves to understand the cultural diversity in your area. Are there certain immigrant populations that you're tending to see? What do you hear from them? What do you understand of their societies, where they're coming from? This is all information that is very helpful in the clinical and program management context, in particular with these patients. Next slide, please. So I'm going to go through this quickly. This is a reference guide for you with reference to what I was just speaking about. I have a workflow management and CHW management recommendation plan here, and it involves the screening of patients for SDOH issues, and then the allocation to a CHW coaching-based system, a CHW-based coaching system. Next slide. Next slide, please. And the guide looks over, it will shows in detail where to put your SDOH screeners, such as the Prepare screener. Next slide, please. And some models for utilization. I put these in here for your reference, and for those of you who are interested in either working with, managing, or altering your SDOH screener, or working in detail with regards to the workflow of your CHWs and patient flow, please email me directly and I can offer some consulting and office hour services. Next slide, please. Okay, and pause here for a second. And this is the CHW model that I'm speaking about here. A patient is identified through an SDOH screener as having an SDOH need. It can be housing, it can be food insecurity, it can be abuse, it can be a range of issues that are both on the Prepare and other widely used SDOH screeners, and information that you may have added to that screener to fit your facility needs, which is something that is recommended and encouraged, by the way. Then referring a patient to a CHW allows the sort of comprehensive support that is necessary for many patients dealing with housing instability. And the coaching-based system, and there are details here and in the preceding pages, the links I put in the bottom left, that links to some research, some details on how to set up that system. But I wanted to make it clear that this is among the best researched and most widely used ways of providing comprehensive support is through CHW-based coaching. In this system, the CHW meets the patient on a regular basis, has the opportunity to build rapport with the patient, and can go through standardized assessments, which include allocation to specific resources. It is an effective way of supporting patient care. And for those of you who are in environments where CHW reimbursement from state or other entities is a challenge or a barrier to hiring, CHW use in health centers has been shown to increase productivity and reduce burnout significantly across clinical staff. So SDOH burnout is a real thing, and having CHWs on staff helps to reduce that for the whole staff. So next slide, please. We're big fans of CHWs at NCHPH. Okay, so this is the fun part. For those of you who come to my sessions, you know that Dr. Lombardi loves case studies. And that's because, let's be honest, they're a great opportunity to reflect on patient care. And the other thing is case studies are so important to understanding patient care and program management. Other than touching and talking to the patient, it's the best tool. And that's from my own personal experience of being trained in medicine and program management. And I feel very strongly about that. So I love doing these case studies. So the way this will go is I will read the case study. It is a detailed case study. And we'll go through some of the information of this patient who is designed to meet this session. We'll then have some discussion questions while I'll ask you all your opinion about the patient care. I really want this to be expressed from your own perspective as professionals doing whatever your responsibilities are. I can see from the chat that we've got a lot of individuals from extremely diverse geographic, professional backgrounds. And I would really love to hear your perspectives on this from your own professional or personal perspective. But case studies are so important, and what we'll do is have those that discussion, and then go back to the case study and discuss how the individual patient care dynamics are related to patient management, program management, and effective clinical care of patients dealing with housing instability. So let me introduce Mr. Rossi. He's a 57-year-old man who presents for a wellness exam. He has a past medical history of type 2 diabetes and hypertension. The patient has a behavioral health history of major depressive disorder, post-traumatic stress disorder, generalized anxiety disorder, and tobacco use disorder. Mr. Rossi is a combat veteran with a history of adverse combat experience in 2007. Your health center has a large veteran population and is in the suburban area of a medium-sized city. When asked regarding his cultural identity and if it will affect his care, Mr. Rossi identifies as white and Italian American and a practicing Catholic, and he notes that none of those will interfere or impact his care in any way. So the patient undergoes a standard intake, comes in, gets his blood pressure checked and so forth, and that includes paperwork, including the SDOH screener, which is my recommended point of placement for the screener in either an EHR or a paper-based format. And the vitals taken tell us this picture. So BP 178 over 98, heart rate of 92, and respiratory rate of 18. So you, the clinician, do a review of the medical records of this patient, and you see in this last report this in the top. Last visit in 2018, his BP was 138 over 98, heart rate was 60, and respirations rate was 18. So this patient has a higher BP, and his heart is going a lot faster than it was 6 years ago. At the time, his hemoglobin A1C was 7.0. And his prescribed medications, he has something for diabetes, something for high blood pressure, and something for depression. His drug screen at the time was negative. Okay. All right. Next slide. So here's the SDOH screener. Let's take a look. So this is based on the WellRx questionnaire, which is a validated SDOH evaluation tool similar to the Prepare screen. At the bottom left, you will see the paper that validates it. And what I like about that paper is it also recommends that organizations amend their SDOH screen to add things that are important. For example, if you are coming from a rural area, you may have more questions regarding transportation and security to add to an SDOH screen than is already present. The recommendations are that you do that, and there's a process in that study which puts that in detail if you're interested. But back to Mr. Rossi. Okay, so in the past 2 months, he has eaten smaller meals because he didn't have money for food. He put yes to homeless or worried you might be in the future. He said yes for having trouble paying his utilities, yes to having trouble finding a ride. Okay. No to daycare. Next slide, please. No, he is unemployed or without regular income. He said yes for needing help for finding a better job. No to needing help with getting more education. No for drug and alcohol abuse. He notes that he feels safe in his daily life, and he puts no to issue to if anyone at home is threatening or abusing him. Okay, so let's take this information and go to the next level of this patient exam. So you are the provider in the exam room with Mr. Rossi. Mr. Rossi is treated by his provider, you, who is also a combat veteran. Upon physical examination, Mr. Rossi is noted to be withdrawn and to exhibit closed body languages. His responses are terse, and he seems irritated. His physical examination is positive for 1+ pitting edema, so his feet are very puffy, and he has darkened skin around his neck and groin area. New results are positive for his hemoglobin A1C went up for 8.2. So his diabetes measures went up. You questioned Mr. Rossi after his clinical exam about his SDOH screener. And here's what he tells you. He worked as a welder until 3 months ago when he was laid off. He has 2 months of unemployment left. He's behind on his utility and his truck is unreliable. He uses Uber and walks for transportation. Mr. Rossi reports more frequent panic attacks in the past 6 months, and 3 times a week versus 1 time a month a year ago. Remember, this is a patient with PTSD and adverse combat experience history. Mr. Rossi is single, doesn't have any family in the area. He receives a 20% disability payment from the U.S. Army every month. And here's an important one. Mr. Rossi has been taking half dose of his prescription medications because he can no longer afford the medication. So Mr. Rossi is asked if he's interested in treatment for his behavioral health conditions or SDOH issues, including the housing instability, but avoids answering the question. When questioned, he notes that he prefers to deal with his private life by himself. When asked why, he notes that in the past he's had difficulty connecting with his providers and that he felt judged. Okay, Fide, let's toss this one up and let's see what we get. Next slide, please. Okay, so this is addressing learning objective 3. What I would like to do is I'm going to take a timer and put a timer on for 3 minutes. What I ask of all of our participants to do is the following. Please open the chat and answer 1 or more of these questions. Answer to the best of your ability, to the best of your perspective, with as much detail or as little detail as possible. I just really want to see where you guys are thinking. When I see that, I will ask for volunteers to share their responses with us. So we're going to take, we are going to take 3 minutes starting now. Fide, I'm timing. And Fide, if you could do the slow cycling through the case. So, there are a lot of details. Thank you so much. And folks, here are the questions in the chat too, as Fide's moving through that. Please tell us your opinion on this patient. What do you think about his clinical condition? Is it getting better? Is it getting worse? And how could you get this patient to seek supportive services? He is resisting them, and you need to find a way to help him. These patients are very common, and they are a normal week. I would run into a couple of them when I was in the outpatient setting, and it can be very difficult to get some folks to accept services that you think are right for them. And a great deal of cultural humility is often required. But anyway, thank you. Okay, one more minute, and then we're going to take a look at our responses.
And then Kevin, also, we have a question in the question section for you.
Do we?
Yes, I don't know if you're able to see it. But I think this is more related to probably may need to get in contact with a housing authority to get more information related to that question. So this one says,
towards the bottom. I can't find it.
Okay, let me read it out now. I am a registered professional nurse as my career. I also have a daycare center in my community. Currently looking for a daycare center to move my home-based daycare center to. Since you work with public housing, please, how can you help with the housing? And then she provided her direct contact information.
Could you please put my direct contact information in there?
Yeah, definitely.
I would love to learn more about and see if I can help you with that challenge. So I put my email in there. Just shoot me an email, and I have office hours where I'd be happy to give you as much time as you need if you'd like to talk about that. And we're at 3 minutes, Fide. So here's how we're going to do it. Fide is going to take, she's our source of wisdom here at NCHPH. So she's going to take a look at the chat and ask folks if they would like to share with us. So Fide, if you could please take a couple and we can hear the opinions of our colleagues about this very interesting and complex patient.
For sure. So we have a response from Rebecca Ibarra. And she said, check medications, look for less expensive options, and speak with PCP for changes. So we wanted to know, I'm going to mute your line and see if you would like to elaborate a little bit more on that response.
Rebecca is one of our repeat offenders here. So Rebecca, it's good to see you, and thank you for your participation. Could you give us your opinion on this? If I'm remembering, you're a CHW. Am I correct? Could you tell the group who you are and what you do?
Okay, can you hear me now?
Yes.
Yes.
Okay. I'm Rebecca Ibarra. I'm a community health worker in Hardy County, Florida, which, can you hear me? Which is a rural county in basically the orange groves and cattle country. One of the first things that I always do when someone tells me, they can't afford their medication is to review their medications list. And the number one reason for that is because even generic options, you may have a tier 1 or tier 2 generic option, and a similar medication may cost less. There's also, it could be on the $4 list at Walmart, where their blood pressure medication that they're currently on is, $30 a month versus the $4 a month. So that's the first thing, and always contact the PCP if we can change some of that out. We also have a couple of I don't know, food pantries for medicine pantries, where donated medications can be redistributed to people in need. So contact those organizations if there's something that he might qualify for there.
Okay, well, excellent. One excellent assessment of the patient. Rebecca is a CHW, and that was a very CHW approach that you assessed the clinical and social condition, and you reflected on resources that were available to you for networking the patient to resources, care, etc. So I really like the information that you gave us from regarding checking the medications. These are these tips that often, if we're in the clinic all the time, we don't understand the technical aspects of how CHWs do what they do. But it's absurd how expensive these medications are to patients who don't have insurance, and networking them to a generic or an affordable option is the difference to it can be the difference between an exacerbation of a chronic illness and a healthy week, or it can be sometimes the difference between life or death for certain patients. So thank you for that, Rebecca, and thanks for your service to your community.
Oh, you're welcome.
Fide, could you take a look and see if there's anything else? And I've read through. We have a lot of interesting replies here. Grab something that's a topic of your interest here, or that's related to the subject.
Sure, definitely. We have a response from Rob okay. By Rob. Mr. Ross's clinical assessment is getting worse and does not seem to trust the system, has transportation issues and financial issues, especially with medications he cannot afford. And he says, I would refer Mr. Rossi to supportive services for homeless vets and connect him to the VA since he has a military connected disability. But Rob, would you like to elaborate a little bit more on this response? I'm going to unmute your line.
Can you hear me?
Yes.
Yes, sir.
Okay.
Thank you. Rob, could you please tell the group your name and where you're from and what you do, please?
Okay, my name's Rob McDonough, and currently I work for Washington State Healthcare Authority, and my job title is a medical respite program manager. But before that, my previous job, I was a field-based community health worker for United Healthcare for 2 years, and before that, I housed homeless vets. Anyway, I'm really connected with my community as far as resources go, and just knowing Mr. Rossi's background after I do the assessments, because when I was a community health worker, we did like several assessments, like the Social Determinants of Health assessment, PHQ-9, determines depression or suicide ideations. But I would definitely connect him to, if he's homeless, I'd connect him to supportive services for homeless vets. And they provide a wide range of resources besides getting him housed. They can also increase his income. But it looks like he gets 20% from the Army each month. So that's good. But also they can help him. I can connect him to the VA, and SSVF will connect him to the VA as well. And they can help him with his health, get him connected to see a doctor. They'll have a case manager to assist him, and also a housing navigator to help him navigate through the process. But yeah, I think, and then what I try to do is I'm a vet myself, and I would say, oh, look, I've been doing this. I know who I can connect you to. If you can trust me, I'll stay in contact with you. I'll follow up with you. Here's my number. Here's my card. But yeah, I kind of know the way Mr. Rossi feels about not trusting his system. He's probably encountered barriers. I can also connect him to transportation assistance. And then yeah, so that's what I would do. And then with my background, I know, and then with the connections I have, I could really help him out.
Yeah, so I love that response, Rob, and you caught what I was hoping someone would catch here, which is that this person is a veteran with an adverse military experience, which we don't know what it was or if it led to his disability, but he is on disability. And it's sometimes shocking to me how many veterans aren't aware of resources that are available to them through the VA medical system. And there's a variety of reasons why they may not use the VA or be aware of those resources. But being able to give them access to them is a huge ability. It gives a huge ability to support them in a myriad of different ways. Because the VA, I've trained at the VA medical system myself at the DC-based hospital, and I think they do excellent care. And some of the best physicians I've worked with have been at VA medical centers, and they have a range of ways to support patients like this. And knowing your resources is another key component here. But Rob, if I could ask you a follow-up as a military veteran, when you are seeing patients who are also military veterans like Mr. Rossi, does connecting with them through your military service help you to communicate with them?
Oh, definitely. There's sort of like a brotherhood or a sisterhood. Like when I was housing homeless vets, I just made a really good connection with them. And when they hear you, like you're a vet yourself and you served, and even though you're probably in different branch of service, you still served, and
Mhm.
you just there's a big connection. And then what I try to do is I try to establish a good rapport with them, so that they can get to trust me. And then
Mhm.
after I build my rapport and I gain their trust, they start to reveal more things about what's going on in their life, which really helps because when they first initially meet you, they're not going to say very much. And after you get that rapport and that trust built, they, they start to open up, and then you can they start trusting you, and they reach out to you whenever they need help. And it just makes things a lot better for your job because you just, you have more information. Um, but yeah, that's the question is yes, definitely. Being a vet, helping other vets, it's a huge, you know, big thing, big connection.
So I got one more for you, and this is for the purposes of non-veteran clinicians like myself. Is there something we can say or do when we are seeing a veteran patient that is helpful or can help us to connect to that patient?
Yeah, I mean, there's some helpful vet resources. Like if you're a non-vet and you're connected to a vet, you can say there's some communities out there like the VFW. They're out there to help other other vets. So if you're not a vet and you got a vet that needs help, like Mr. Rossi, you definitely want to connect him to some veterans groups, and they can connect him to resources that you probably don't even know, or even me as a vet, because there's so many resources out there for vets. And so that would be my answer to your question.
Hmm. Well, thank you for that, Rob. And I will say that as a non-veteran who's served veterans for a long time, and I know that these are folks who are, generally speaking, very focused on their own self-sufficiency and sometimes can struggle to ask for help, especially with the older ones I've had experience with. Now, I found that something simple like just saying thank you for your service or something of the sort can be a good conversation opener for a patient. Like that. But thank you for your input on that, Rob. And Fide, can we pick one more? And I realize we're coming to 10 minutes, but the rest of the slide is mostly consulting. Slides are primarily consulting resources, which I will go over at the end. Could you pick one more for us, please?
Sure. I'm going to unmute the line for Shannon Goen. Let me see. Hi, Shannon.
Hello.
Hi, how are you doing? Could you please elaborate a little bit more on your response?
And first, Shannon, if you don't mind, could you please tell us the community you serve and how you serve it, please?
We serve we're at, well, it's Green Bay, Wisconsin, so we're not too small, but we do have an increasing number of homeless people. What we do here at our clinic is we help those who are homeless in get like subsidized housing or don't have any insurance or low insurance. We just recently got a mobile health unit, so we are trying to get that going because transportation here is huge. It's a big barrier for healthcare. And I have worked in the nonprofit world for about 4 years. Well, 12 years. I used to work here and then I came back. So I'm elaborating because we do have a lot of these. We have noticed since COVID, especially the homelessness has increased. Rent has gone crazy high here. I'm sure that's everywhere. And even though we got some assistance with housing, it's kind of all drying up. So we're struggling a lot with that. And what I discussed is what we see a lot coming into our clinic. They're pretty stressed out right now, and him being a vet, he really needs someone and resources that he can go to, that they'll understand and hear him, really hear him, you know. So
Well, thank you for sharing that perspective, Shannon. And I know many of our constituents are dealing with similar challenges with the rise of patients who are dealing with a homelessness status and being unhoused. And my ask for you is that for the purposes of this discussion, when your organization started noticing that you were dealing with a lot more homeless people, homeless individuals in your clinic rooms, what were some of the first steps you did, or first steps you took to start to try to manage that?
well, before I've only been back at this organization since December, but in the other nonprofit I worked at, we really took a step back and really looked at the community health worker model and really tried to grab those clients that came in and treat them as a whole person and try to say, just not get them in and out, like try to build trust and try to coach them so that they don't feel so overwhelmed. And we did a lot of ourselves, trauma-informed care and diversity and equity so that we could help relate to those individuals that maybe we don't have that. You know, I'm not a veteran. I don't have that trauma that they had, but just even learning how to help those individuals so that they can be heard is something that we really took a huge investment in our clinic, and then I hope we continue to do where I am now.
Well, I mean, that's great to hear because, you know, when I hear reflect on your narrative, Shannon, what I hear is integration of data-driven practices is really what I hear. And you know, the epidemic of unhoused individuals is something that provides a number of challenges for us in the clinic. And one of them is that sometimes even when you're doing better, it's hard to see. Because it's such a huge issue that it can be overwhelming at times. But integrating those data-driven models and providing that whole person comprehensive support is the best data-driven practices we have for managing those patients and supporting them through these challenging times in their lives. So thank you so much for that. And thank you all for your participation and reflection on this patient. Now, Fide, if you could scroll through the next ones for the next slide, please.
Thank you, Shannon. Thank you, Robin. Thank you, Rebecca.
So here I highlighted all the important parts, but if you could go through the case, Fide. But another thing that, as she's doing that, you can keep going, Fide. But I just wanted to mention something that was a key aspect here is that patients that are on housing choice vouchers, if they are evicted, they are at danger of losing their voucher. And a resource that's particularly helpful for supporting patients is a medical legal partnership. Having a medical legal partnership allows you to have a lawyer that can make those phone calls and stop that process. And health centers are increasingly utilizing medical legal partnerships. And Fide, if I could ask you to throw in the National Center for Medical Legal Partnerships website in there. If any of our participants are in the position to consider or to utilize medical legal partnerships in their own practices and would like to start a system, I would recommend you reach out to our NTAP colleagues at the Medical Legal Partnership NTAP. If you could pop that in, Fide, I'd appreciate that.
Yep, yeah, working on it right now.
Thank you. And then Fide, if you could bring us back to that slide, please.
Yep.
And reflecting on our comments here, reminding a patient that they had served and that now it's time to take advantage of services available to them is another thing that's good. Another statement that can help to encourage patients to reflect on the fact that they should use these resources. So we will not have time for this. I would love for this to be a 5-hour session. But this is a continuation of Mr. Rocky's case. This is a continuation of. Fide, I'm getting feedback. Are you? It must be me. Excuse me. So continuation of Mr. Rossi's case. I encourage you when you get the slides to look through this and answer and reflect on the questions. This is his work one-on-one with the community health worker. Can you just breeze through those, please, Fide? Fide, could you, yes, please. And next, please. Okay, so I'm going to take a few minutes for Q&A here. If you have a question, throw it in the chat or raise your hand. And otherwise, I will be hanging out for a little bit here if anyone would like to reach out and speak with me. If we have any questions, please put your hand up. And Fide, it looks like we are good to go. Could you take the ball, please?
All right, so while we wait, if we have any questions, this is just a kind of reminder to everyone to please complete our post-evaluation survey. And today we heard about some really good best practices that are related to today's topic. So we did include a question in the post-evaluation survey about whether you would be interested in showcasing your promising practices in one of our upcoming sessions. That would be really great. So just let us know if you'd be interested.
Give us an opportunity to promote your clinical excellence.
And so, yeah, and that is it for today. We don't have any questions in the chat. So we hope that you guys have enjoyed today's webinar.
I will say my email is right there. That's me, Dr. Lombardi. Please don't be shy. Reach out. We are funded by the federal government and happy to provide office hours or support in whatever way we can. So please do reach out.
Well, thank you so much and have a great rest of your day and your week.
Okay. Bye, everyone.